the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Carmen Presti. She is a nurse practitioner and she wrote the Kevin MD article, Remove Race from Clinical Guidelines. Carmen, welcome to the show.
Thank you, Kevin, and thank you for this opportunity to share my perspective.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Sure. Nursing is my second career, so I've been a critical care nurse since 1999, acute care nurse practitioner since 2007. I also teach at the University of Miami, and I'm an assistant professor there, and I teach the acute care nurse practitioners. And I'm so happy I have two jobs. I also practice as a acute care nurse practitioner in the cardiovascular ICU, and also I float to the general surgery ICU where I see transplant patients, general surgery patients, but really my area is cardiovascular surgery, post-op care. I take care of patients with left ventricular assist devices, heart transplants, ECMO, and then your cabbages, valves, thoracic surgery as well. I'm also an op-ed fellow, and this is a group that promotes underrepresented voices in the media. And so this was my impetus for this op-ed, as well as another op-ed that I recently was able to publish in the US News and World Report. So that was kind of the push, even though for the last couple of years, I think like many of us, my eyes are starting to open a little bit about issues related, around racial inequities and disparities in healthcare. So I have many jobs. I'm also the secretary of the Miami chapter of the National Association of Hispanic Nurses. So I'm trying to get more involved as well. I am Cuban born and raised here in the States, so I am Hispanic. So all of those things have come together to help me look at some of these issues that I didn't learn about in school, and I'm not really hearing about in the clinical.
So one of the things that we always talk about on Kevin MD is it's important for us in healthcare to have a voice and speak out, because as you said, this isn't something that is often taught to us. So tell me, was there something that lit that fire to really write an op-ed and speak out and share a voice and share your stories? Was there an event that made you want to do this?
I think I wrote about COVID disparities in healthcare and cardiovascular disease disparities because Black Americans are, the number one, disproportionately affected group of cardiovascular disease. And when I started to look into that topic, because my unit also became a COVID unit, as many of ours did, and I did float to even other areas in the hospital. So I really started to see that disparity. And that kind of triggered me to start to look at cardiovascular disease disparities. And it started to open up the conversation for myself of why are Blacks and people of color more, ill, die more often, have worse outcomes than their white counterparts. And race as a construct started to show up for me. And then, recently the estimated glomerular filtration rate, guidelines have shifted and have been shown to be really, there's no true evidence by stratifying Blacks differently than whites, scientifically or biologically. And, that kind of, both of those things started to come together for me. I talk a little bit in the article about a patient that I had when I was first a trauma ICU back in the early 2000s. And this patient had suffered devastating burns from almost head to toe. And when I walked into the room to manage the care of that patient, the first thing that struck me was that, first of all, I couldn't identify what their race was. And then next was, does it really even matter? Am I going to take care of this burn victim differently than I would someone who was, whatever the color of their skin was? So that's always stuck with me for years and years. And it's funny because when I shared this idea with a non-provider, a non-healthcare person, they said, "You're going to really tell me that you didn't know what race they were?" And I said, "No, honestly, I could not tell." And that patient always stayed with me. Here it's many, almost 20 years later and And I still think about that. And is it different? You know, is the melanin in our skin really that much of makes us biologically that much more different than, others? And should we be tailoring clinical guidelines to that? So I think that was kind of a long answer to your question, but it wasn't one particular thing. It was almost, like several topics coming together for me.
Your article is titled Remove Race from Clinical Guidelines. Now, for those who didn't get a chance to read your article, what are some other examples where you see race influencing clinical guidelines through your lens in the critical care unit?
So I teach. So this is another thing that is important for me, is that I'm teaching ASCVD, risk prevention for atherosclerotic cardiovascular disease. And I bring up the calculator every single time, and I kind of show students how they would input patient data and then how the risk changes depending on the data that you put. And sure enough, when you put the black versus white, the risk is higher, for atherosclerotic cardiovascular disease, just based on that one factor. Is the patient black or is the patient white? And as you see the numbers change, it's what am I teaching here? That just because a person is black, that they're going to be at high, risk for atherosclerotic cardiovascular disease. And is that really true? And, back in the early 2000s, the Human Genome Project discovered really that we're over 99% the same biologically. We're all one race, Homo sapiens. And so therefore, how can we be tailoring all these medications, screening tools, management interventions based on that point, whatever it is, 0.06, I think, or maybe another estimate is about 2% different. And so what I discovered, which I was kind of surprised, because again, this is not something that I really learned on my own, was that really a lot of our differences are more on geographic migration patterns out of Africa, not on our color. And truly scientifically, we really are only one race, which is the Homo sapien race. And I delved into that, and I was astonished to find really how science has had these discriminatory views, even though after 2000, when we were able to map the human genome, we discovered that there's really no evidence, no scientific basis, and geneticists called out, Francis Collins, who just retired from the NIH, called out, a stop in using race in studies and guidelines and medicine, really, as a defining factor. So why do we keep doing this? And I started to discover that these policies, these concepts really run deep in our history in medicine in the 1800s, and really up until even 1937, we had a eugenics study going, which was basically supporting the idea that we should have a clean race of superior white, people. And I was floored. The other thing that I was surprised about was when I talk about this issue, one thing that was great about getting this op-ed accepted and being able to share it with colleagues was how some of my provider colleagues, some attending physicians, were very aware of this problem, and others that are fellows. And I'm so lucky to work in a teaching institution where I can tap into what's going on today, in training of fellows, is that a fellow that I work with who's very bright, brilliant person had no idea any of this. So I think we're not showing this side of medicine and where some of these policies actually came from, and these ideas of using race, as a factor and defining race based on our color biologically.
Now, can you share a story or a case study of how an example of a race-based clinical guideline led to a disparity in care?
So actually, recently in 2020, the New England Journal of Medicine put together a beautiful perspectives article, and they went through several areas. And this is just not even a comprehensive list, but in cardiology, the Get With the Guidelines heart failure risk score, actually gives more points of risk for patients that are non-Black. Cardiac surgery, the Society of Thoracic Surgeons uses a risk calculator and basically puts Blacks at higher risk for surgery. So you can obviously see then that patients that may need surgery may be deferred because they're too high risk because they're Black. And it goes on. The FAR that I talked about with estimated glomerular filtration rate always gave Black people less risk because they were Black. So, the connotation is then they're going to be sicker anyway. So you shouldn't start treating them earlier, which doesn't even make sense. Organ procurement and transplant, obstetrics, vaginal birth after C-section, even other, how we calculate UTIs, renal cancer survivor. There's quite a bit of tools that are based on obviously, clinical guidelines, osteoporosis risk score, pulmonary function test. These give a real difference in how they're scoring Blacks versus non-Blacks, and not in favor of Blacks getting better care. Actually, the reverse of that. They often lead to less care, less intervention, and reserve higher resource-based treatments to non-Blacks. So the disparities are there, they're real. They go across multiple, areas of specialty. It's not just, American College of Cardiology or, ADA. It's really rampant, and there's no good. We are supposed to be science-based, right? And there's no good scientific reason for why we are using race in these calculators, in these guidelines. Now, what there is good reason for, which I'm assuming you might, is social determinants of health, right? So some people, yes, are going to have less access to good, healthy food, to exercise, have more stress, have, lower paying jobs, less access to healthcare, less education. Absolutely, we are seeing those disparities, and they show up in healthcare. But it's time that we call things for what they are, which is truly why are Blacks more prone to some complications from diseases and it's not because they are Black. It's not that they have an inherent weakness or a biological reason for getting sicker. It's because they are not receiving the same access to healthcare, education, good paying jobs, nutrition, the ability to exercise, right? I mean, the AHA can say you gotta do 150 minutes a week of cardiovascular exercise, but if you live in a neighborhood that there's no sidewalks and you can't pay for the gym, and it's not safe for you to go for runs or long walks, then obviously we're not calling things for what they are. We're labeling a race instead of looking at the disparities that we have in society.
We're talking to Carmen Presti. She's a nurse practitioner. She wrote the Kevin MD article, Remove Race from Clinical Guidelines. Carmen, what do you envision the next steps to be to help remove race from clinical guidelines?
Well, I think it's time that when we put together these boards, across these societies, that first of all, that we are well represented, people of color are well represented, and start to speak their truth about why do we need race here? What's the underlying? Is there a scientific reason for it? We did see the eGFR removed now. We really, I think personally, need to tackle cardiovascular disease, right? Because this is the #1 killer and has the I would say the largest amount of disparity in care and management. So it's going to be time to be looking at some of these guidelines that are up. They're due soon, and this is just really a call for scientists, healthcare providers, researchers, geneticists that are sitting on those boards to examine, the use of race in clinical guidelines, and to start to instead use tools that identify inadequacies in those social determinants of health, which, by the way, are really where we work, live, play, and live, those determinants that really do put some of us at higher risk for poor outcomes in healthcare. So start to call things for what they are, start to screen patients appropriately. Do they have housing? Do they have access to good food and so forth, like I mentioned before? Start calling those issues out for what they are, not blaming it on someone's race. So that's really what I would like to see happen in the next few years now when these guidelines go up for review.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
My take-home message is that question everything. When we're providers and we're prescribers, especially nurses, physicians, question what you're doing and why you're doing it. And ask yourself, is this at the best interest of my patient? Should I prescribe a calcium channel blocker, or should they really get an ACE inhibitor? Just, because a guideline says so, maybe they have great reason for it, and maybe it doesn't. We have to start to question things and take a risk. Ask those questions that are difficult and be curious. Be curious about what you're doing for your patients and why you're doing it, and talk to the patients. I've heard people say, oh, this patient, their organ failed because they became non-compliant. I go and talk to the patient and I find out that it's not because they were non-compliant, it's because they had a gap in their healthcare coverage. And that 1 month of not being able to afford their anti-rejection immunosuppressive medication made them reject their, so ask questions, be curious, and be a patient advocate.
Carmen, thank you so much for sharing your time and insight. And thanks again for being on the show.
Thank you.